And we are happy that Dr. Subhadra Jalali is around us. And no electrophysiology society or conference or a forum is complete without her. Thank you, madam, for coming. Thank you very much.
We welcome madam.
So I'll be talking about multifocal ERG and fulfill ERG. Friends, now you have learned about different kinds of electrodes and the machines and everything. So one of the most important tests that is done in ERG is fulfill ERG. So you have to take the precaution that you do not do any test of such kind that you put light into the eyes of the patients, like inert ophthalmoscopy or lasers or fundus fluorescent angiography or any for that matter, any examination. You must dilate the pupil fully, and it is better that if you can measure the pupil, because many a times we have to calculate how much light entered into the eye. And the dark adaptation has to be 30 minutes, and if you have done any procedure before that involving light, then you have to further increase the dark adaptation time, probably up to 1 minute or even 1.5 minutes, half an hour. So for fulfill ERG, the DLT electrodes are the most commonly used, and a lot of people are using even Jerry electrodes. They are the active ones, and the reference electrodes are put in the outer canthus, and the ground electrodes are put on the forehead. So there are certain tests which are done in the dark adapted area time, and there are certain which are used in photopic conditions. So let's see one by one. If the patient is in the dark and you start stimulating, the stimulation has to be very, very substandard, and please see that there are certain amount of stimulation time, and there are certain strength of the stimulation. See, you have to mark that. We have given you a handouts in which it is mentioned there. So the first test, it is done very, very substandard light, and the interval between the two flash is approximately 2 seconds. And the source of the wave is from the rods, basically, and it generates from the inner nuclear layer. If you slightly increase the flashlight up to 3 cannula, and the interval is 10 seconds, then you can see the A light is a little better, but this is mainly from the rods and little bit from the cones also, because there is light is on the higher side. And if it is the 10 ERG with a stronger flashlight, you get this is also a scotopic, and the light intensity is on the higher side, that is 10 candela, and the interval between the two flashes are 10 seconds. So it visualizes the A wave better. If the light intensity is only 3 candela lights, but the intervals are every 15 seconds, then the waves that are generated are from the amacrine cells, which is at the ascending wave of the B wave. B wave is from bipolar cells. Now the patient is adapted to the light, and then you give this stimulation. Then let's say the patient is light adapted for more than 10 minutes, then a single flashlight is given from 17 to 34 candela. There is a standard flash, and the interval between these stimuli should be more than 0.5 seconds. The source of wave is A wave and plus part of the bipolar cells, and B wave is basically B for bipolar. Then there is a flickering of the lights. This flickering of the light should be more than 30 flashes per second or 30 hertz. It suppresses the rod system because there is no gap in between, so it suppresses the rod system. What you get is only cone bipolar cells stimulations and their waves. It is a more sensitive measures of the cornea. So by this time we know that if you have to check the rods, you go for the dark adaptation test. If you have to check the cones, you have to go for the light adapted tests. So these are the different kinds of waves you get. So we have talked about the photoreceptors, and mind you, this is a full field ERG. So if there is any damage, a little bit of damage, you have to have at least 20% of the damage of the retina to give you any result or negative result. Suppose if the patient has got some problem in the macula, it may come normal. So if you go to the periphery of the retina, you can see there's a lot of rods and cones and a lot of retinal pigment epithelium, then less of rods and cones and less of bipolar cells and less of ganglion cells and then less of axons. So what you do if you go towards the periphery, you the scotopic and photopic phenomena, you get the recordings from the photoreceptors, and in the visual evoked potential that tells you about the ganglion cells less. In the macula, what happens is there are a lot of retinal pigment epithelium and then a lot of cones, and a lot of cones get attached to a lot of bipolar cells, a lot of bipolar cells get attached to a lot of ganglion cells, a lot of ganglion cells get attached to the axons. So if you stimulate the macula, you are stimulating most of the cones. So these are the normal responses. And in a normal condition, what we do is we compare both the eyes, the normal eye and the abnormal eye, that is suspected abnormal eyes. So this is normal in both the eyes. Suppose if there is a case of ischemic ACR view, you want to know whether the patient will gain vision or not. So for the prognosis, you can do this test and you can see that the B wave is the amplitude and the implicit time both are reduced. There are hardly any waves there. In a cone dystrophy also, the cone is gone, all the cone function, all the cone waves are not there. There are many such. We can talk to Dr. Subhadra Jalali and ask her for opinions. There are something like negative ERG also, in which the B wave is little lower than the A wave. They happen in certain conditions. It's there in your handouts. You can go through it. Now the multifocal ERG is very important. It is a new technology. Initially, it was supposed to be investigative in nature. Now it is developed by Professor Sutter and Trans in 1992, and your first direct, objective, and topographic mapping was center 36 to 40 degree of retinal function in the center. Multifocal ERG responses are cone-driven, and it tells you about the health of the fovea, parafovea, near peripheral protopic retina can be evaluated. It provides high-resolution spatial and temporal information from the retina. There are frame changes, and it changes very fast, and these changes are from the CRT monitor. That is, you have seen the checkerboard in the center. It comes from there. So there are a lot of focus in the macula area which gets stimulated. There are approximate somewhere it is 65 to 103 hexagonal stimulus array. They stimulate that area. They pick up the wave. And for this multifocal ERG, you have to have the pupil has to be dilated. The patient positioning should be approximately 35 centimeters from the screen. The fixation point is very, very essential. And you will see in your chart, which I have handouts, that in certain cases you have to dilate the pupil. In certain cases you have to correct the refractive error also. So refractive error has to be fully corrected. The patient should be pre-light adapted. And the stimulus recording, if you suspect some disease, so disease eye has to be examined first, and the impedance level should be less than 10. So impedance level, the machine tells you whether the impedance level is okay or not. If the impedance level is not good, the machine will not proceed further. So you have to correct the impedance. What is impedance? It is noise. There is some problem. So you have to sometimes you have to change the lead. So waveform, they are grouped in a different retinal eccentricities. Horizontally it is 35 degree and vertically is 31, and the viewing distance is approximately 35. The responses are obtained from the 6 zones. So why 6 zones? Because there are a lot of toxicities of the diseases of the drugs, which are they show the abnormality in the 2nd zone, or sometime in its 3rd zone. And since it is a topographic mapping, so it makes your life very easy to understand whether this is normal or not. So it is always compared. On the right hand side is normal, the left is diseased one, and Stargardt's disease. So it also gives a wave, the positive wave and the negative wave. The positive wave is the P wave, and negative is N1, and you can measure the implicit time of in milliseconds and response in nanovolt. But we do not calculate that. It is the mathematical summation, and the machine gives you the overall picture. So friends, if you do have to check macula, multifocal ERG tells you the cone system function at the macula, because there are a lot of cones there. And the other function at the macula could be PERG, that is the pattern ERG. That tells you about the some amount of receptor cells and about the ganglion cells there. With Dr. Bibuth will be talking about it. So what is the application of the MFERG? That is macular dystrophies, central serous retinopathy, drug toxicity, inflammatory conditions. And this again chart is given to you in your handouts in different conditions. What should be the refractive error and visual acuity, etc. And what are the waves to be observed? People have talked about so much. What are the waves? In full field ERG, you have to observe wave A, B, and C. In flash VAP, you have to see N2, which is very important, which is approximately 100 millivolt. The implicit time should be 100. And in pattern reversal VAP, P2 is important. In EOG, Arden ratio is very important. And in PRG, N50 and N95 are important. So if you suspect certain diseases, what all tests should be done is there in the handouts. That is very, very important. So this is one of the normal ones. So it looks normal. On left hand side is the eye which was tested, and by just a glance you see that it looks normal. So